So the CDC published a review on hepatitis E sometime last year, and they called hepatitis E as having two faces. And I think as the data has emerged over the last 10 years or so, I think this is a very apt and a very appropriate way of describing hepatitis E. And the picture really for hepatitis E differs depending on what part of the world you're looking at. So the picture for the developing world has been well established. We've known about it for a very long time. But where new data and a new understanding and re-evaluation of Hep E has really come from data coming out of the industrialized countries. So we have a distribution of various genotypes from what we see in the developing world to what we see in industrialized countries. This is probably not surprising. But we have very stark differences in transmission routes, but also in reservoirs of infection in different parts of the world. The disease pattern is very different. And also where we, in particular at PHE, have been on a very steep learning curve is looking at outcome of infections. We see a very high mortality, say, in pregnancy in the developing world, which we don't actually see here. So I hope you forgive me, but today I'm going to mainly focus on the picture in industrialized countries, purely because this is new, it's led to re-evaluation of the virus. But I will talk a little bit about data from the developing world as well. Just to start off with a little bit of history, so we know that hepatitis E has been around for many, many years, but it wasn't actually recognized as a separate clinical entity until the 1980s. So up until this point, hepatitis A was thought to be solely responsible for these very large waterborne outbreaks that we saw through the developing world. But questions began to be raised as how these epidemics could continue to occur year in, year out, even though these individuals had known immunity to hepatitis A. And then with the progression of time, as new and better kits became available for Hep A, it became quite obvious that there was a separate agent causing these large viral hepatitis outbreaks. So it was really the Russians who first gave experimental evidence of a new agent, and I think it was actually the lead author in this group who actually ingested a fecal suspension from patients who had a Hep A-like disease. He collected his own stool samples and then did a bit of immune electron microscopy and quite clearly showed evidence of 30-nanometer virus-like particles in his stool. This was successfully transmitted to monkeys, and the virus was named epidemic or enterically transmitted non-A, non-B. But the diagnosis of the virus is very limited for a long time because immune electron microscopy was the only thing that was available. But then more recently, in the 1990s, the genome was successfully cloned and sequenced, and we now have what we call the hepatitis E virus. So certainly in the developing world, up to this day, hepatitis E remains a major public health concern. It's responsible for over 50% of acute viral hepatitis throughout these regions. So transmission through these regions is through the consumption of fecally contaminated food and water, and really is associated with a breakdown or a poor infrastructure, in particular in dealing with human sewage. The disease itself is fairly self-limited, and not all infections are clinically apparent. There's about an up to 1% mortality rate in the general population, but this increases dramatically to anything between 20 to 30% in pregnancy, and obviously associated with very poor neonatal outcome as well. Why this should be so is still not very well understood. But unlike hepatitis A, hepatitis E actually transmits very rarely from person to person. So one of the issues when we're trying to look at hepatitis C through the developing world is the lack of data. There's very little data in terms of seroprevalence rates, but also of incidence. Most of this has come out of India, and so this is what some of this data shows here. What we see in data from India is that majority of infections actually occur in males, and there is this very specific clinical attack rate, with the majority of infections actually occurring in that young adult male population. So majority in males, but also in the young adult male. So through the developing world, through Africa, Indian subcontinent, the Middle East, and also Mexico, we have genotype 1 and 2 viruses that circulate, and they've only ever been reported in humans, never in any animals, just in humans. So as well as causing sporadic infections, they are associated with these very, very large waterborne outbreaks. So this is a slide from the WHO website. It's a little bit out of date, but really just to demonstrate to you when these outbreaks happen, they do affect many thousands of individuals, and even many tens of thousands of individuals, where we've seen outbreaks in sort of India and also through China. And they can place a massive burden on these populations. It's just a graph here showing the outbreak that occurred in Uganda a few years ago. And I put it up really just to show that when these outbreaks occur, they can be very protracted, lasting even a couple of years. So the first cases were really seen in October 2007, and the CDC came in about a year later, and by this time there had been just over 3,000 cases and just under 70 deaths. The outbreak then peaked, and as it petered away towards the end, there had been about 10,000 cases, about 150 deaths. And the majority of deaths were in that population you would suspect, mainly in pregnancy, but also in very, very young children. So we were at the WHO last year to talk about hepatitis E, and what was particularly interesting was the MSF came to give a talk on an outbreak that they were dealing with at that time, which was occurring in Darfur, and where we see majority of outbreaks are now in displaced individuals. And what they demonstrated quite clearly is that when these outbreaks occur, they put a lot of pressure on these aid agencies that are working under very difficult conditions, but also a lot of pressure on what is very, very much a vulnerable population. And I think what they were asking for is actually a tool that can be used to try and manage some of these outbreaks. And what is also very exciting in the last couple of years is the availability of hepatitis E vaccine. This has been asked for a very long time, but has not been available. But a vaccine called Hekelin has now been produced by the Chinese and has recently been licensed for use in China in those aged between 60 to 65 years old. The vaccine is based on a truncated part of the capsid region, and when it's expressed in E. coli, it self-assembles into a virus-like particle. There's been a lot of work done on this vaccine. The safety looks very good, and the immunogenicity and efficacy data is also very good. The vaccine recommends 3 doses, but the investigators actually show that if you have 2 doses, you do get a good antibody response in 98% of individuals. It's highly protective against hepatitis E disease. And even though the vaccine's not been around for very long, I think protection has been shown to extend to at least up to 4 years. So there is clearly a tool available now, but I think we will see how this can be used in trying to manage some of these very large outbreaks that occur. So I'm now going to move on to looking at hepatitis E in industrialized countries, and I'm going to talk mainly about the picture in England and Wales, but this is very similar to what we see throughout all of Europe. So certainly in the UK, we have for many years thought hepatitis E was just an imported infection. So individuals traveling to known endemic regions, and certainly for us, it was mainly individuals traveling to the Indian subcontinent, coming home and presenting with illness. But we now know that the virus can be acquired indigenously, that virus can be acquired in this country. We've done a lot of molecular characterization work, and we have a different genotype in this country to what's seen in endemic regions. We have genotype 3. And we've worked with the mathematical modelists at Colindale, and they tell us that we have about 60,000 cases of Hep E that occur per year. So this number is very high, because we've only actually relatively recently found the virus. But it does suggest that we have a high rate of asymptomatic infections. And I think as we've learned a lot more about the virus, I think this is a very true feature of this virus. So we've tried to look at how much of the virus sort of burden that we have, and we did some seroprevalence studies, and this was done in 2004, and we have about an overall seroprevalence rate of about 13%. So we've got an incredibly high rate of antibody prevalence. So very different to the picture I just showed you about seroprevalence rates through India. What we see is an increase in HIV seroprevalence with age in our population, and it peaks about 20 to 25% in those aged 50 and over. So where is the virus coming from? How is it being transmitted through the developed world? So the detection of HIV antibodies and RNA, and this was initially in pigs, but it's subsequently been described in other farm and domestic animals. And this really led to the suggestion that the virus was transmitting via zoonosis and that these animals act as a reservoir for infection. So the pig really remains the best studied animal for hepatitis C, and wherever it's been looked for, you always find a very high seroprevalence rate of hepatitis C in pigs. So certainly from our own data, we know that the genotype 3 viruses that we find in our cases, whilst they're unique, they cluster very closely with British pig sequences. There's also now very good evidence to show that food acts as a great vehicle of transmission for hepatitis C, and the first of these came from studies from Japan where individuals became infected following the consumption of raw or undercooked deer or boar meat. The French have also shown that the consumption of figatelli, which essentially is a Corsican pig liver sausage, which they usually eat raw, was linked to 3 separate outbreaks. The French have also done a case-controlled study on their confirmed cases, and they showed that the consumption of game meat, processed pork, and mussels was associated with hepatitis E infection in their cases. So we and others have also started to try and look at possible transmission routes in England. The epidemiologists at PHE did a case control study in 2012. They took 25 of the cases that we identified in the lab, and they matched each of those to 3 controls. They then went through a fairly extensive food-based questionnaire. What meat they ate, how they handled it, how they cooked it, did they eat out, where did they eat? So it was fairly extensive, and they went through a fairly extensive statistical analysis. And at the end of the day, it showed that there was a clear association between the consumption of pork-based products and Hep E infection in our cases. The AHVLA have also did a study which was published in 2012, and they actually provided evidence of hepatitis E contamination at each stage of the pork production chain in the UK, and actually showed that 10% of sausages were Hep E RNA positive at point of sale. Whether that virus was viable, we don't know, but certainly they were RNA positive. So we at what was Health Protection Agency and now PHE, we've been doing enhanced surveillance for the virus for the last sort of 10, 11 years now. And we've been collecting data on numbers, but also on demography. And what we see in our acute hepatitis E cases is the majority of cases occur in men, and also in that slightly older age group. And this is a year that has trend that has stayed the same year on year. It hasn't changed at all. The majority of acute hepatitis E occurs in the older male. Somehow they're much more susceptible. We've also been keeping an eye on numbers, and what we see over this 10-year period is that the numbers fluctuate quite dramatically. And what we've seen since 2010 is there has been this year-on-year increase in case numbers, and the case numbers for 2014 are actually higher than 2013. And we are in this period of heightened activity for hepatitis E. There's a lot of hepatitis E around in the UK. If we break this data down a little bit more, in blue is the total number of cases, and we can see in green are the total number of cases that are associated with travel. So that's individuals traveling abroad, and I say majority of infections come back from the Indian subcontinent. But what we see over this 10-year period is the number of cases due to travel has stayed fairly steady, between 100 and 200 cases a year. That really hasn't changed very much at all. But what has changed is the number of cases that are acquired indigenously within this country. And as the number of cases have gone up, so have the total number of cases. So there's acquisition in this country that is leading to this upswing of case numbers. So I apologize, I know this tree is not very easy to look at, but what we've been doing at the lab is every time we get a virus coming into the lab, we sequence it. We sequence across the capsid region. And here we see all the genotype 3 viruses that have been circulating in Wales over a 10-year period. And what you see is the virus actually splits into 2 very distinct groups. And what we've labeled this group up here, group 1, and this group down here, group 2. At the end of every branch is a coloured dot, and that coloured dot represents the year in which that virus was circulating. And what it allows us to do is actually put a little bit of a timeline. And what we see is that the majority of the viruses up here were circulating in 2003 to 2009. The majority of viruses down here have been circulating much more recently, between 2010 and 2013. So just to look at this in a slightly different way, group 1 viruses, which are the top half of the tree, were the dominant virus from 2003 and really until about 2009, 2010. And then we start to see the emergence of group 2, which is the bottom half of the tree. And it really now is the dominant virus that's circulating in our population, is what we've seen in 2014 as well. So I think collectively what the data shows is that there has been a change in the magnitude of risk of acquiring hepatitis E in this country. And as the case numbers have increased, it does seem to be associated with the emergence of a group of viruses that weren't commonly circulating prior to 2010. So the question really remains whether these viruses are much more transmissible, and therefore we're seeing a lot more infections. Or whether these viruses are a little bit more pathogenic, and therefore we're seeing a little bit more clinically evident disease, and maybe more people are rocking up to their GPs. I'm not sure that I have the answer to those questions. But certainly from a public health point of view, what we have been keen is to try and understand how those risk factors have changed. This could be down to changes in farming practices, in animal husbandry, or the way we process our food, or certainly in importation of meat into this country, because we actually import a lot of pork meat into this country. So just to try and answer some of these questions, we've become much more engaged with organisations such as DEFRA, FSA, but also the pig industry. And they were undertaking a national survey of pigs at slaughter in the UK. And this was done in the first quarter of 2013. And it was focused on 14 abattoirs across the UK. And they actually slaughter about 80% of UK pigs. So it's actually quite a representative study. So we took the opportunity to try and look at hepatitis E in the pigs at slaughter. So a number of pathogens were looked for. Our role was to look at hepatitis E, and we were looking in plasma. We looked at antibody, RNA, and also did some sequencing. So the antibody testing actually showed that about 93% of our pigs are antibody positive. And I think this is what we would have expected. We know usually pigs have a high seroprevalence rate. If we have a breakdown of the antibody response, we actually found that over half have evidence of a recent hepatitis E infection, while just under half actually had resolved their infection by the time they came to slaughter. About 6% of those samples were actually HEV RNA positive, and the antibody profile suggests actually they were in the early stages of an acute hepatitis E infection. So even though these pigs were in that slightly older age group, there was evidence that they were having an acute hepatitis E infection, and therefore there was a risk of these animals entering into the food chain. So I'm just going to park the pigs for a little while and go back to the human side. So certainly at PHE, our public health remit for hepatitis E has grown dramatically over the last couple of years. And that's really because of the recognition and the characterization of chronic Hep E infections. So this obviously has, again, made us rethink what we traditionally thought to be true for hepatitis E, which was traditionally thought just to be an acute infection. But now we have description of chronic hepatitis E infections. And they have a very typical picture of chronic hepatitis E, and we have had some evidence of cirrhosis in some of our patients. So all reports thus far of chronic Hep E have been in an immunosuppressed population. So the prognosis for these individuals has remained very poor. Some of the data coming out of the transplant settings suggest that if you reduce the level of immunosuppression an individual is on, it will lead to viral clearance, but only in about 30% of cases. But these cases are now being treated successfully, and this is both in the transplant and the HIV setting. And they're being treated successfully using drugs typically used to treat hepatitis E. So that's ribavirin or interferon therapy. And this is either in combination or as a monotherapy. So the treatment regimens do vary between reports, but I think ribavirin monotherapy is rapidly becoming the drug of choice. It's incredibly potent. We see a very rapid drop in viral load with very little side effects. So chronic hepatitis E in the HIV setting has been described, but not very often. We've only ever seen 3 cases in England and Wales. And when there is described, there is a very typical picture. There's low CD4 counts. Even though the individual is on an antiretroviral treatment and their viral load is controlled, they have persistently raised LFTs. And even in these individuals, when we see them developing an HEV antibody response, it's not always associated with viral clearance, and does suggest there is an impairment elsewhere in the immune system that's leading to viral persistence in these individuals. So 2 of our 3 cases were treated. Unfortunately, the 3rd case died. His liver disease progressed very quickly. But 2 of the cases were treated, and when they were treated successfully and once the viral load had cleared, it was associated with a recovery of CD4 counts in these individuals. But where we see majority of chronic hepatitis E is in the transplant setting, and we're seeing that more and more. We probably get a case a month at the moment. It's increasingly recognized, and I think it's mainly because there's much more awareness, and I think therefore a lot more people are doing a lot more testing. We've got about 25, maybe 30 cases, and this is mainly in the solid organ transplant patients, but also a few cases in heme-oncology patients. We have been on a very steep learning curve about how to manage and treat these patients, and each patient has been very different, and dealing with each clinical team and the level of immunosuppression really dictates how that patient will be managed. So I just wanted to sort of round up by talking about another transmission route for hepatitis E. Again, this is something that's come up very recently, and again, we've been asked to alter a lot of our practices and our understanding to do with hepatitis E, and that is the transmission of Hep E through blood. And there has been a growing momentum, both here in the UK, but also across Europe, to try and address the issues of Hep E and blood safety. So studies that we've done, as well as others, have quite clearly showed evidence of hepatitis E turnover in our donor panel. And we have had a number of cases of post-transfusion hepatitis linked to HEV, and that's from the UK, but also from other parts of the world. And certainly in the UK, we give a high proportion of our blood components to the immunosuppressed population. And obviously, as this population are more at risk of developing chronic hepatitis, we really need to know what the issue is with regards to Hep E and blood safety. So we set up a study. It was a joint study between ourselves and NHS Blood and Transplant. And really what we wanted to do was to define the incidence of Hep E infection in our donor panel, to look at the extent of transmission of virus-containing components and look at the outcome of receiving those components. And it's really the last 2 points where there hasn't been any data with respect to hepatitis E, and that kind of data was really needed to try and inform the discussion and debate that was ongoing about Hep E and blood safety. So we looked at just under, about 225,000 individual donations, and we had about an incidence of just under 1 in 3,000 donations being HEV RNA positive. So quite a high rate of HEV incidence in the blood donor panel. So when we look at the donors themselves, all of them felt well at the time of giving donation. So despite them being highly viremic, all of them felt well enough to come and donate blood. And when we looked at the antibody profile, nearly 3/4 of those that were infected were actually seronegative for antibodies. And we know with hepatitis C that the development of the antibody response is really what leads to the development of symptoms. So maybe it's not surprising that the majority of donors actually felt well enough to come and donate. So we had 79 viremic donors, and they generated 129 components. And it was a whole range, red blood cells, pooled and apheresis platelets, FFP, cryoprecipitate, and pooled granulocytes. So under the ethics that we held for the study, if any of those components were still available when the HEV RNA result was known, they had to be discarded. So just over 50% of the components were discarded. But we did transfuse 62 of the infected components. And just to note, even though we had 62 components, we only had 60 recipients, because unfortunately 2 recipients were unfortunate enough to receive 2 lots of HEV-containing components. So the big thing was really for us to try and look at transmission rates. So each of the recipients was followed up for a minimum of 16 weeks. We were unable to get information on 17 of those 60 recipients. Some of them died very closely after receiving the transfusion. Some of them were very ill, and it didn't seem appropriate for us to go in and then try and initiate investigations for hepatitis E. But we did follow up 43 recipients, and at the end of that 16-week period, 18 had evidence of Hep E infection, giving us a 42% transmission rate, so a fairly high transmission rate. And we confirmed transmission from donor to recipient by sequencing of the virus. So we started to look at particular factors that may be associated with hepatitis E transmission, and I think one thing that was significant was the virological factors. When we looked at antibody itself, the presence of antibody itself was not an important factor, but the level of antibody was. So those donations that had a higher level of antibody, in particular high levels of IgG, they were less likely to be associated with a transmission event. And maybe unsurprisingly, those donations that had a higher virus load, much higher viral load, were more likely to be associated with an HEV transmission rate, event. So the level of antibody and the level of RNA was certainly important. So I think when we started this study, we thought we would get a high incidence in our donors, and we thought we would get a high transmission rate. But I think what we weren't clear about was what the outcome was going to be. And what we saw is that of our 18 recipients, as the level of immunosuppression increased, so did their duration of infection, and so did their median weeks to seroconversion. So the more immunosuppressed you were, the more likely you were to have a persistent virus that did not clear. And what we saw in those individuals who were more severely or moderately immunosuppressed, even though they developed an antibody response, it wasn't always associated with viral clearance. So they're, again, showing there was an impairment in the immune system, which was allowing the virus to persist. So looking at the clinical outcome of Hep E infection, I think it is quite complex because each individual has its own underlying conditions, and each of them had a different level of immunosuppression. We certainly know that you get evidence of prolonged viremia in the immunosuppressed, and I think 2 years on, one of our patients is still viremic. The clinical team have taken the decision not to treat him. But we do get in some patients, development of an antibody response, and in some patients, that lead to viral clearance. But in some patients, some of the clinical team decided to intervene. One patient, viral clearance was achieved by putting them on ribavirin, and the other two, they actually reduced the level of immunosuppression the individuals were on, and that did lead to viral clearance. So I think there are quite major issues about Hep E and blood safety. We clearly have a high incidence in our donors, a high transmission rate, and we have evidence that when we give these components to the immunosuppressed, it is leading to persistence of the virus. So the question really remains that whether the NHSBT will introduce screening for hepatitis E, because we don't screen for Hep E at the moment. So the Department of Health have an advisory committee, which is SABTO, which advises on safety of blood tissue and organs. And they have formed a subcommittee, and they are reviewing the data, and they will give an outcome. I think it's due in March as to whether we should be screening blood for hepatitis E. So hopefully I've hoped to demonstrate to you that our understanding of this virus has changed dramatically over the last 10 years. We now recognize there are differences in transmission routes, disease outcome, and disease pattern associated with the virus, and this does seem to be related to the genotype of the virus. Data that has emerged over the last 10 years has really changed our understanding, and particularly in industrialized countries. We now know that infections can be acquired indigenously, and that it's associated with rolling infections, which are linked to zoonotic transmissions, and that we have quite distinct animal reservoirs for this virus. I think what has been particularly important for us in terms of public health is the recognition of chronic hepatitis E and its management, and how it can lead to chronicity in the immunosuppressed. The risk of transmission through blood and blood products has also raised very important questions. But I think there are areas for additional studies, especially I think from the developing world. I think a lot more work is needed to get a better understanding of the prevalence and incidence of data from these parts of the world. It certainly is lacking in majority of these countries. I think the availability of hepatitis E vaccine is very exciting, and I think it'll be interesting to see how aid agencies and the WHO explore the use of the vaccine in outbreak situations. We certainly need to do a lot more studies in trying to understand how hepatitis E genotype influences clinical outcome. Certainly more locally, we need to get a better understanding of why we have this increase in Hep E cases and why we're in this period of heightened activity. And while we like to point the finger at the pig, I think we need to get a better understanding of possible sources of Hep E infection in our population. And I think probably by Easter, blood safety concerns will be addressed, and we'll see what the outcome is from the Department of Health. I'd like to stop by just thanking the following people. Thank you very much.